Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight we will hear Dr. Michio Hirano's June 2022 symposium presentation with the opportunity to ask questions via the Q&A button throughout his presentation. Dr. Michio Hirano comes to us from Columbia University, New York, and is a current member of UMDF's Scientific and Medical Advisory Board. Our moderator this evening is Margaret Moore, UMDF Support and Education Associate. The floor is yours, Margaret.
Okay, I would now like to invite Dr. Michio Hirano to join us. Hi, Dr. Hirano.
Hello, Margaret. Hello, everybody.
Thank you so much for joining us today. I want to give a little explanation to our adult community about how things are going to work today and what might be a little bit different. So the way it's going to work is we are going to be showing you a pre-recorded presentation that Dr. Hirano did at Mitochondrial Medicine 2022. And we're going to be taking a pause 2 times actually during the presentation and then one at the end for questions. But don't hold your questions. Dr. Hirano is here and he can answer your questions while the presentation is going. If you need to understand how to use the Q&A, there is a Q&A button at the bottom of your screen and you can type your question in there. Dr. Hirano will see them, and if he is able, he will answer those questions. So pretty excited about that. Also wanted to mention that we host a monthly adult virtual support meeting. It's always on the first Thursday of each month, and I would love for you all to join us. There will be an event calendar posted in the chat. Please go there and take a look. Let's get ready. We'll go off camera and the presentation will begin.
All right, so this session is mitochondrial disease, what to expect as an adult. And I was given 3 topics to cover, but I think I'll cover the first 2 rather quickly and focus more on the 3rd topic, and I'll show you what these are. Let me just make sure. Yeah, I was told that there was here. All right, I'm going to just start with some background information so everyone's on the same playing field. I think probably all of you know this, that mitochondrial diseases are clinically and genetically heterogeneous, and they're hard to diagnose. Many of you have gone on diagnostic odysseys for months or years to get to your diagnosis of mitochondrial disease. They are rare. That's part of the reason they're difficult to diagnose, but not so rare. 11.5 per 100,000, so probably 70,000 people in the United States or more with these conditions. And among the inherited neurological disorders, they're the most common. And these disorders, as you know, affect virtually every part of the body, but they particularly affect the brain and muscle, which are organs that require lots of energy. And obviously, mitochondria are vital to produce the ATP energy, as we've heard recurrently through this week. And so they're genetically heterogeneous because they could be due to a variety of mutations in the mitochondrial DNA, nuclear DNA, or sometimes even nuclear DNA mutations that cause secondary mitochondrial DNA mutations. And one of the unique features of mitochondria and mitochondrial DNA is that the mitochondrial DNA is exclusively transmitted from mothers to children, and that that DNA is present in hundreds of thousands of copies per cell. And so you can have different levels of mutation in a cell, and from one cell to another, the level can vary. In general, you need really high levels of mutation to cause disease, usually over 70%. But because these mutations are present in different levels in different people, the same mutation will cause different diseases in a family. So all of these people in the maternal lineage, starting from up here, this grandmother, to her children, to their grandchildren, all have the same mitochondrial DNA mutation, but at different levels. And that's why this here, the one in the dark circle with a line through it, that means the patient passed away, had severe me loss because they had high levels of the mutation. Oops, sorry. And you can see the levels of mutation in muscle and blood, and they vary from patient to patient. But this person who had the most severe problems and passed away in early childhood had 95% mutation in muscle and 85% in blood. And this person here who has no symptoms has the mutation in muscle, but it's undetectable in blood. Okay. And that's shown here is schematically showing that different cells have different levels of mutation. So the blood cells have less mutation, muscle have higher levels of mutation. And that's generally true for these mutations. We have the North American Mitochondrial Disease Consortium, which is comprises 15 active sites across the United States and one in Canada that's investigating mitochondrial diseases on a research basis. We have a registry, so I encourage you to, if you're seeing a physician, a mitochondrial specialist at one of the NAMDAC sites, to sign up for the registry so we can collect information about all of your mitochondrial diseases. And we're learning quite a lot about these mutations. The most common diagnosis among all of these patients is multisystemic disease, meaning there are 3 or more organs are affected, but not in a particular pattern, not the classic MELAS or MERF or Hirano syndrome. It's something else that we haven't been able to define yet clinically. So it's challenging if you don't have a particular syndrome to call it a mitochondrial disease. So we label them multisystemic syndrome or other clinical syndromes, and many of these patients lack a genetic diagnosis. We do see that there are 2 peaks. There are the young children here in the blue wedge of the circle that have mitochondrial DNA mutations that have mitochondrial disease, and these are generally due to nuclear gene mutations, recessive mutations. That means the parents are each carriers but not affected, but the children who are affected have 2 mutations, one from the mother and one from the father, and they can be very severely affected in early childhood. And then the other group is what we're here talking about, adults who have mitochondrial disease, and they could be due to these various nuclear gene mutations shown here in the red. The most common one is Pol gamma. Then in green are the pyruvate dehydrogenase complex deficient patients, and then many of these patients many of these genes are represented by only a single patient. There's only one patient in the registry with that particular gene defect, or so these diseases individual diseases can be very rare. And we do see, as I said, that Lee syndrome is more common in young children, so it's different from the adults who tend to have these other diseases like MELAS, chronic progressive external ophthalmoplegia, Leber's hereditary optic neuropathy. And we see that the adult onset patients are more likely, twice as likely to have a mitochondrial DNA mutation than a nuclear gene mutation. So these were the 3, well, this is the first of the 3 subjects, general subjects that I was asked to talk about. I'm going to cover the first 2 of these quickly. So mitochondrial disease and age-related conditions. And so aging, Parkinson's disease, Alzheimer's disease. Did anyone here request this topic? No? Well, I'll just go through these quickly. It's well known that as we get older, our mitochondria don't function as well. I mean, and some people think that that's the cause of aging. That we get as we get older, we have less energy, our muscles get weaker, our muscles become smaller, sarcopenia, and we develop problems like hearing loss, vision problems. Sometimes that's just shown here, fatty liver, diabetes is more common as we get older. And so it may be that the mitochondrial maintenance is not perfect. We're not able to undergo mitophagy, swallow up these damaged mitochondria and get rid of them through this mitophagy pathway. Unfolded protein response. It's a way of getting rid of misfolded proteins. All of this may not work perfectly, and over time we accumulate damage to the mitochondria, which then causes mitochondrial DNA damage, reactive oxygen species, and proteotoxicity. Those abnormally folded proteins accumulate and cause toxicity in mitochondria, which then cause all of these other problems, including oxidative stress and and contribute to aging. So we know that if we do a muscle biopsy of people normal people who are over, say, 60 years old, we'll see a few ragged red fibers and a few deletions of mitochondrial DNA, and that's normal. So it is part of the aging process to have some damage to mitochondria. And there's even a mouse model. This is a mouse model with a genetic defect in the polymerase gamma. I mentioned one of the most common nuclear gene that's causes of mitochondrial disease. And when in this mouse model, there are some features of aging. And you can see here, this mouse here has developed kyphosis, a bent spine, and has lost weight. And these mice with this polymerase gamma accumulate mitochondrial DNA mutations over time, and in some ways mimic the aging process, and they die or prematurely compared to their normal litter mates. There are mitochondrial diseases without ragged red fibers. For example, Leber's is one good example. All right. There are a number of connections between mitochondria and Parkinsonism or Parkinson disease. Parkinsonism is a more broad term and includes Parkinson disease, which is the classic sporadic late onset disease. But there are other causes of Parkinson disease-like conditions, like boxing. Muhammad Ali had Parkinsonism. He didn't have classic Parkinson disease, but from the damage to the brain from repeated brain trauma, he developed Parkinsonism. So there were some early reports of mitochondrial complex 1 deficiency in Parkinson disease. And it was detected in blood and platelets, and there was a suspicion that maybe complex 1 deficiency was the cause. It's not really, it's still not clear. This hypothesis got further attention when this neurologist in California, William Langston, identified this group of young people who were developing Parkinsonism. They were young people in their 20s, and they had taken a designer drug called MPTP. And that drug is like Demerol, and they were using it recreationally, but it was converted to this other metabolite called MPP+, which blocked complex 1 and caused Parkinsonism. So that's indirect evidence that maybe complex 1 deficiency causes Parkinsonism. Parkinsonism, certainly, maybe even Parkinson disease. There are some pesticides, rotenone, paraquat, that are complex 1 inhibitors, and epidemiological studies have linked these pesticides to Parkinson disease. So there are multiple lines of evidence, indirect, but suggesting that. And then there are these rare genetic forms of Parkinson disease that are due to mutations in alpha-synuclein, Parkin, PINK1, DJ1. And I won't go through the mechanism, but just say that they're all, the proteins are all associated with mitochondrial functions. So again, implicating mitochondria in the pathway of Parkinson disease and Parkinsonism. And then that polymerase gamma I told you about being common as a common nuclear gene cause of mitochondrial disease, and that mutator mouse with Pol gamma mutation that mimics aging. We also know that polymerase gamma mutations can cause Parkinsonism. It looks very much like Parkinson disease. So there are these links. So it's intriguing, but not really proven that there is this link. And in Alzheimer's disease, there are a number of hypotheses about mitochondrial dysfunction. Problem is, we don't know if these mitochondrial abnormalities are truly pathogenic, causing Alzheimer's disease, or they're bystanders, because it's hard to know. And my colleague Eric Schoen has this new idea that perhaps even more specific than mitochondria, that there's this region of the mitochondria that is associated with the endoplasmic reticulum called MAM, and that's where there's a lot of lipid metabolism here, but that's also where the amyloid precursor protein is processed, and he thinks that there are defects in this MAM that are causing Parkinson's disease. There are lots of hypotheses. Bottom line is we don't know. All right, so that's the aging, Parkinson, and Alzheimer's disease story. The second topic I was asked to address is mitochondrial disease and fatigue. So how many of you are, with mitochondrial disease or your family members are affected by fatigue? Okay, I see the vast majority here. So fatigue is a major component, and for many years it was overlooked, but it is really a huge problem. And we don't know if it's simply due to lack of ATP production and just running out of energy, or if there's something else going on. But it's clearly there. And here, this is a study done by the Newcastle group, in which they used a survey, fatigue inventory score, and they looked at the scores in patients with mitochondrial myopathies here, and patients with controls, and patients with chronic fatigue syndrome or myalgic encephalomyelitis. And you can see that the patients with mitochondrial myopathies have higher levels of fatigue based on this scale. So that's clear. And in a sort of related study, the group at Children's Hospital of Philadelphia, led by Zoella Kipley-Cunningham, did another survey where they asked patients, what are the most common symptoms in your mitochondrial disease, and which of those symptoms would bother you enough to participate in a clinical trial or motivate you to participate in a trial? And the answers were 1, 2, and 3: muscle weakness, chronic fatigue, and exercise intolerance. Would some of you agree with that? Yeah, that's really bothersome. Yeah, I keep hearing stories of people with mitochondrial disease who complain that if they do routine activities, they do laundry, they're wiped out for the rest of the afternoon. They go shopping, and then they're wiped out not only for that day, they're tired the next day and achy. So it's a frequent story I hear from people. And not surprisingly, that these symptoms would motivate people to go into clinical trials. So it's really fortunate now that there are 2 companies, that are 3 actually, that are targeting primary mitochondrial myopathy as in their trials. So their drugs are targeting that. And one of the things that they're measuring is not only strength, but fatigue. So it's now recognized as an important part of mitochondrial disease. Before we go further, is there anybody want to maybe make any comments or questions about their fatigue? Yeah, I think it's partly, if not all, due to ATP, and we can measure that by different ways, including there's an MR spectroscopy technique where you put a person's leg in a machine and you have them pump up and down on a pedal, and their ATP level is normal in the beginning, but then as they exercise, the ATP level drops, and then you do serial scans and see the ATP level rise again. And it's much slower in patients with mitochondrial disease. So that indicates that probably they're depleting their ATP, and they're not repleting it because they can't make it as fast as a normal healthy person. So that indicates that. There is something you could do, I think, to counteract this. That is exercise. You can do aerobic exercise, and a number of studies done by Tanya Tyvaso, Ron Haller, who are exercise physiologists, have shown that aerobic exercise, such as bicycling or swimming for 30 minutes every other day, can be beneficial in improving exercise capacity, increasing the number of mitochondria, kind of like making ragged red fibers in the muscle by increasing the number of mitochondria. And it can improve your quality of life. However, in practice, I mean, I think that there's a window of opportunity there, because you could do this maybe relatively early or mid phase of a mitochondrial myopathy, but when you're really weak, you can't do 30 minutes of exercise. So maybe 5 minutes of exercise every other day is as a better target initially when you're starting out. You don't want to hurt yourself. And I generally tell people, if they're achy for a couple of days afterwards and they're in bed, then obviously they've overdone it. So you have to titrate your exercise when you do that. And another way to look is to check your blood CK. CK is an enzyme that's in the muscle, and when you damage your muscle, it leaks out. So you can measure your CK before and after exercise, and if it goes way up, you've probably overdone it. You've damaged your muscle. I want to
Hi, Dr. Hirano, are you ready to come back on screen and have a little discussion?
Yes.
That was super interesting, and thank you so much. The fatigue topic is really interesting to me, and is something that comes up in our adult virtual support meetings pretty much every single time we have a meeting. Are there other things that you think people can do to relieve their fatigue?
Yeah, it's a really huge problem for the mitochondrial disease community. And I think really people have to deal with it on an individual basis because every person's fatigue is a little bit different. So they have to learn what are the best coping mechanisms for that fatigue. Is it avoiding certain activities or planning your schedule ahead of time to knowing that certain activities are going to cause fatigue and then building in time afterwards to rest and recover. So I think it really has to be titrated, and I'm sure in the support groups, people talk to each other and they talk about their experiences and learn from each other. So I think that's a very valuable way to deal with it, is talking to each other and learning from each other how your symptoms occur and what you do to avoid them and what do you do when you experience them. And unfortunately, I think the best medication for fatigue is rest.
I think so. I wish I had more of it. I do want to comment right now that our next installment of the Ask the Mito Doc webcast is going to be on January 11th, and the topic is energy conservation. Mm-hmm. So we're going to be talking about ways that people can use their energy and sort of parcel it so they get to do the things that they really enjoy and are not wasting it on things that aren't going to be helpful to them. So we're looking forward to that. It will be again on January 11th at 7 p.m. Eastern. The other topic that I kind of wanted to go over that we touched on very briefly is one of the things that's difficult for adult patients, and very specifically, is finding a doctor. What are your thoughts? Many of our patients are diagnosed with children and become adults and have to transition from the pediatric world to the adult world, or some doctors don't make them do that. What do you think is a reasonable way for a family to approach that situation of finding a new doctor when they are aging into the adult world?
Yeah, it's a huge problem. I think there are probably more pediatric doctors who treat mitochondrial disease at this moment than adults. So there seems to be a great shortage of adult physicians for our young people who are transitioning into adulthood and for our adult patients in general. So I think you could start with your current team of pediatricians and pediatric mitochondrial specialists, since they know the community that they serve, and they can probably refer you to someone locally, but that's not always possible. And so if there's not an adult counterpart for that pediatrician in that particular hospital system, you may have to look elsewhere and look at resources like, UMDF can sometimes help. And certainly there's the NAMDAC, North American Mitochondrial Disease Consortium, which has sites around the country, as well as the Mitochondrial Medicine Society. So these are all resources that can point you to centers, at least, where you can hopefully be in contact with an adult mitochondrial medicine provider.
Oh, well, that's a wonderful point. And another thing that I wanted to bring up is that sometimes it really helps if a family is transitioning to an adult primary care physician, mm-hmm. that they make sure that physician visits MitoU for clinicians. We have mm-hmm. a full host of CME courses that physicians can take to learn more so that they can take better care of their patients. And so that's also a way to get somebody interested in Mito. I think that information, and especially it's free, it's a really good resource. So families should be thinking about that when they do embark on getting any new doctor. I think we probably want to get started again, and we'll move back into the presentation, and we'll see you in a few, Dr. Hirano.
Okay, great, thanks.
I wanted to focus more on these issues because I think these are things that most of you are going to be confronting, because mitochondrial disease patients are generally more likely to undergo surgical interventions, whether it's biopsies, sometimes tracheostomies, G-tubes, and other surgical procedures. So I think you need to be, well, prepared for this. And again, please stop me at any point, because this is, I think these are important issues for you. And there's very little evidence regarding the safest and most effective anesthetic regimens. And because of this heterogeneity that I mentioned before in mitochondrial disease, it's not possible to give uniform guidelines that apply to every single patient. Every patient has to be titrated to some extent. Okay, sorry. Okay, and in general, most mitochondrial patients tolerate anesthesia well. And there's little evidence, of, as I mentioned, about what is the best and safest. But there are risk factors, let's say, for complications. And these depend on the involvement of certain organs like the heart, the lungs, or respiratory muscles more specifically, and elevated lactic acid. So if you have these abnormalities, you're more likely to run into complications. In general, we tell people to avoid fasting or minimize it, and to, obviously you have to be fasted during surgery, because you're going to be, if you get general anesthesia, you're going to get intubated. There's risk of vomiting, aspiration. So they try to minimize that by having people stop eating the night before. But you can minimize the problems of fasting by starting IV fluids and giving dextrose intravenously. And this is a good source for information about surgery and anesthesia technique, complications and recommendations from the Newcastle mitochondrial website. Okay, and actually a lot of this information comes from them. So, okay. So see some of these specific factors that are important in stratifying patients for surgical risks are, as I mentioned, heart, muscle problems, including respiratory and bulbar muscles, seizures, gastrointestinal dysmotility, and lactic acid elevation. So cardiac conditions. So heart is frequently affected in mitochondrial disease. I said there are brain and muscle diseases, and heart is another muscle. So cardiomyopathy, that's pretty common. Any of you have heart involvement? Okay, a few of you. And it can be, heart it can be enlarged, hypertrophic cardiomyopathy, they can be dilated. There are a few other abnormalities of heart that can occur. Or you could have abnormalities of the electrical system of the heart, cardiac conduction abnormalities like cardiac conduction block. The electrical system may have a block in it, and that's very common in Kearns-Sayre syndrome. Or this pre-excitation syndrome, Wolff-Parkinson-White syndrome, which may predispose to tachycardia, whereas the heart block could predispose to slowing the heart, bradycardia. So it's important to see a cardiologist and also a mitochondrial specialist, both as part of your routine evaluation, but especially before surgery. And often the surgeon and anesthesiologist will ask for cardiac and mitochondrial clearance because of the heart issues. At the very least, you need a routine electrocardiogram and maybe an echocardiogram prior to the surgery. Okay, and if there is a problem with the heart and there's cardiomyopathy, you have to be very careful with the fluid. How much fluid? I told you you stop the eating the night before, but then you start an IV when you get to the hospital, and then but you want to make sure you don't fluid overload, and then your heart doesn't pump, and you accumulate fluid in your lungs, and that could be bad. All right, myopathy is very common. How many of you have muscle weakness or exercise intolerance? Yeah. Okay. Again, common problem. And patients with mitochondrial disease often have exercise intolerance out of proportion to weakness. And you may look normal and you may have pretty good strength, but you poop out quickly. Okay. And the muscles not only affect the limb muscles, but respiratory muscles. So the diaphragm, intercostal muscles can be weak, and this causes restrictive lung disease. It's what the pulmonologists describe it as. But also bulbar muscles. So we know that chronic progressive external ophthalmoplegia, ptosis are common, but also swallowing muscles, oropharyngeal muscles can be affected. And that's an important surgical procedure, any procedure, because if you have trouble swallowing, you're at greater risk for aspiration and aspiration pneumonia. So that needs to be considered. And then because you're weak, you may not walk around as much, and you may, and immobility increases the risk of blood clots, deep vein thrombosis in the legs. So you have to prophylactically treat for that, prevent that from happening. Okay, so the recommendations are, if there's suspicion of restrictive lung disease, consider pulmonary function tests and consult a pulmonologist. And if you haven't seen a pulmonologist for a while and you're going to surgery or thinking of having surgery, go back and have it checked again, because your respiratory muscles may get weaker, and that needs to be assessed probably before surgery. And then, as I said, the swallowing issues are pretty common, particularly the combination of ophthalmoplegia and dysphagia. A lot of people with CPO have dysphagia. So that increases the risk of aspiration pneumonia. So that's important to know about and be prepared for. And then, of course, as I mentioned, prophylactic therapy, anticoagulation to prevent deep vein thrombosis. All right, these are pretty, often these are done routinely, but it's especially important in mitochondrial patients. All right, seizures are very common in mitochondrial disease, multiple diseases like Paul gamma, Melas, Murph. So one thing we generally tell people is to avoid valproic acid if possible, particularly in Paul gamma, because that can precipitate hepatopathy, especially in the young kids with Alport syndrome. It can cause a really severe fulminant hepatopathy to be fatal. Our general recommendations for mitochondrial disease patients who have seizures is to continue the anti-epileptic drugs through this perioperative period. But if you're NPO, you're not able to eat or swallow pills after midnight, you may have to get the medication intravenously. And then all of your medications could have interactions with the things that they're going to prescribe during the surgery, so that has to be checked out. If there are interactions between your anti-epileptic drug and your anesthetic. All right, and then if a seizure develops at any time, preoperatively, during the operation, or after the operation, it needs to be addressed urgently, obviously. Oops. So any questions or comments about seizures? Well, pretty straightforward, I think. I mean, a lot of these recommendations are just common sense, but important to think about. All right. Gastrointestinal dysmotility, often overlooked in mitochondrial disease. So a lot of patients have problems with diarrhea, constipation, abdominal bloating after eating, early satiety. You eat a little bit of food and you get full very quickly because you don't empty your stomach quickly. Esophageal dysmotility. Sometimes food gets stuck in your throat, and even swallowing difficulties in the oropharynx. They're all part of this gastrointestinal dysmotility spectrum. All right, particularly in Mingi, but in Melas as well. And it may be subclinical, meaning you may not even know it's there. But during surgery, it may be unmasked. All right, and the surgery often worsens. That's why these problems become unmasked during surgery, because it's very common, because the anesthetic and being immobilized in bed, the intestinal system doesn't contract as well, and you get a paralytic ileus or nausea, vomiting, gastroparesis. So the motility issues can get worse, and even in normal people, there are some problems with GI motility. So if you know you have gastrointestinal dysmotility problems, good to consult a gastroenterologist to take care of it in general, and consult them before the surgery as well. And we prefer conservative management of gastrointestinal motility, dysmotility, rather than any procedures, which can make things sometimes worse. And then frequently nasogastric tubes are inserted during the perioperative periods as a way to feed and give medications. All right. And as I said, if necessary, surgical intervention is sometimes done for GI dysmotility, but we try to avoid that. One patient of mine who had a liver transplant recently, had Mingi, developed GI bleeding, gastric bleeding actually, and it was not controllable. And then they ended up taking out 80% of the stomach to get rid of to halt the bleeding and get rid of the source of the bleeding. So sometimes it is necessary to do. It's very rare, fortunately, and drastic, but sometimes surgical intervention is necessary for these GI problems, but we try to avoid it because you end up with adhesions and other problems after GI surgery. So we don't like to do that. All right, lactic acidosis. So that's very common, but not uniformly present in patients with mitochondrial disease. We use it as a diagnostic test. And if it's present, it's helpful. But absence of lactic acidosis doesn't exclude mitochondrial disease. All right. And it's important in this surgery period that to know that lactic acid may be elevated at baseline. And because surgeons and the ICU teams and the recovery room teams may measure lactate and they think, oh, this is a sign of distress. Maybe this patient has an infection, maybe he has sepsis, maybe there's hypoxia, maybe there's a small bowel perforation. And it may be just that's the normal baseline lactic acid. So it's important, as you'll see in the recommendation, to get a baseline lactate measurement before the procedure so you know where you're starting from. And patients with a very high baseline lactate are probably at greater risk of surgical complications just because the body is straining to make energy using anaerobic glycolysis there. And so there's the system is more compromised and more vulnerable. So absolutely important to get a baseline blood lactate prior to surgery, preferably get it from the venous blood or arterial without a tourniquet. And it's not uncommon to see a mild to modest elevation of lactate after surgery, but if it goes way up, then you might need to be concerned. Some people recommend avoiding lactated ringers because that is as an IV solution. But as Mark Tarnopolsky recently pointed out to our group, lactate is actually an anion and may actually buffer the acidosis, but anyway, it may elevate the level of lactate. So in general, I think it's probably a good idea to avoid lactated ringers just because it may confuse the picture here. All right, preoperative consideration. Okay, before the surgery, it's important to consult your mitochondrial disease expert, go over these issues, and other specialists, depending on where your problems lie. If you have heart problems, see a cardiologist, gastroenterologist for GI motility issues, and so on. And often the surgeon or anesthesiologist or both will request letters of medical clearance from your specialist. All right. And then the people who are doing the procedure, involved with the procedure, need to be aware of all of these factors we've gone over that increase the risks of complications or during and after the procedure. So some of the baseline things you need to do before procedure is routine bloods, including, but not, and some not so routine things like venous lactate. CK is good to measure for reasons we discussed before. Calcium, magnesium, hemoglobin A1C, which is a marker of diabetes. EKG, it's often done routinely, but especially important in mitochondrial disease. In patients who are known to have gastrointestinal dysmotility, it's maybe good to get an abdominal X-ray before the procedure to see what the colon and the small intestines look like. If they're dilated at baseline, well, we know that's the baseline. And then after the procedure, if they do an abdominal X-ray and they see that the intestines are dilated, they'll say, oh, well, it was present at baseline. It's normal, because dilated intestines can be a sign of ileus, but if it's present at baseline, it's not something new caused by the surgery or the anesthesia. So having a baseline EKG and abdominal X-ray can be very helpful in interpreting these studies after the operations. All right. Anesthesia consideration, there's no, as I said, no good evidence regarding the safety and efficacy of routinely used anesthetics. In general, as I said, anesthesias are generally well tolerated. And as I said, propofol is generally considered safe. There are some exceptions for just the induction of anesthesia, but prolonged propofol should be avoided, absolutely. So that because propofol is toxic to complex 1 of the mitochondria, can really cause damage. And unfortunately, we've seen cases of children who had Lee syndrome and had propofol anesthesia, and they developed brain lesions because, well, probably related to the surgery and possibly related to the propofol. This question often comes up: is there increased risk of rhabdomyolysis, muscle breakdown, due to mitochondrial disease or malignant hyperthermia? And to our knowledge, in general, no. Right? There may be a few cases, but generally, no. Johan, have you seen? Yeah. I have not seen any cases of rhabdomyolysis or malignant hyperthermia. There are other genetic myopathies where that may happen, like ryanodine receptor mutations that are known to cause malignant hyperthermia, but not in the case of mitochondrial diseases. Okay, and then we discussed this before. It's important to stay well hydrated during the perioperative procedure. But if you have bad heart and you have congestive heart failure, you don't want to overdo that. So you're walking a tightrope there. All right. Any questions about these anesthesia issues? All right, and then after the surgery, the recovery may be delayed. Your cognitive, you may be slow in waking up. Motor functions, may be weak. Respiratory functions may be compromised after you don't breathe as well. But it's important to try to take deep breaths, and they give you that device that you inhale, incentive spirometer. It's important to do that to fill up your lungs and avoid atelectasis, which collapses your lung, and which could predispose you to pneumonia. So, but be aware your recovery may be delayed. And make sure you stay hydrated and take adequate calories because fasting or dehydration can be harmful for people with mitochondrial disease. Hyponatremia is sometimes seen in patients with particularly MELAS or the M3243 mutation that seems to be more prone to hyponatremia, low sodium in the blood. And then the IV fluids can be adjusted to give you normal saline or even hypertonic saline if necessary. And then we talked about this before, deep vein thrombosis prophylaxis, giving Lovenox or other anticoagulation to prevent clots in the legs. All right, and then other postoperative issues. Diabetes has to be managed because diabetes is common in mitochondrial disease. So in the same way as other forms of diabetes, except that you should avoid metformin if possible. Urine output should be monitored. Again, absent or reduced urine output should be rapidly assessed. For other causes, that could be renal kidney damage, and you need to know about that early so you could intervene quickly. Bowel care, we talked about the dysmotility issues, and there are particular diseases like Mingi or MELAS or the 3243 mutation that tend to have more GI dysmotility problems. So it's important to identify the constipation early and initiate this bowel regimen to try to normalize the bowel movements. And then, preoperative bowel care is important. And then often patients get opiates, morphine or other drugs to reduce the pain from the surgery, but that will cause constipation. So you want to minimize the use of opiates if possible. And then, as we talked about, sometimes if there's ileus or suspicion of ileus, abdominal x-rays are done. But again, it's important to have that baseline study before the surgery so you have something to compare with.
Hello, everyone. Sorry about our little glitch there in the middle. Hopefully you were able to hang tight and are still with us. Dr. Hirano, there were a couple of things that came to mind that I thought we might want to talk about. One of them is with the adult population, there are some clinical trials that have popped up. Can you talk a little bit about that and what our families or adults can look forward to?
Yes, so it's very exciting for us that the pharmaceutical industry is interested in mitochondrial diseases. Previously, we thought that they were so rare that the pharmaceutical companies wouldn't be interested in developing drugs, but they are. And we are very fortunate now that several companies have been involved with a variety of mitochondrial diseases. And most of these clinical trials are targeting adult patients. So there are a group of trials that are targeting patients with primary mitochondrial myopathy, that is weakness of the muscles with exercise intolerance or a combination of the two. And there are particular companies, Astellas, Reneo, and Stealth Biotherapeutics that are targeting that group of patients. There are other companies that are focused on specific mitochondrial diseases, subtypes, such as MELAS, and there's a company called Cyclerion, which is very interested in MELAS. And then, of course, I've been involved with a company originally called Modus Therapeutics, and they were acquired by Zogenix and most recently by UCB, and they're focused on thymidine kinase 2 deficiency. And that's a disease which affects both adults and children. So that has a wider age range, but a very specific disease. So there are a variety of clinical trials, and the United Mitochondrial Disease website has a very nice website where you can look up these clinical trials and find one that might be suitable for you. And I urge you to, as patients or families, to really explore the clinical trials. I think we need to work together. We need, of course, patients to participate together. We will work together with you and the pharmaceutical companies to test these new promising agents and see if they work. This is the only way we're going to get drugs approved by the FDA is by doing these very rigorous clinical trials, which are necessary to prove safety and efficacy of drugs. So we really need to work together as a community. So I urge you to consider joining clinical trials and registry studies so that we get more information about the drugs, about the diseases, and the natural history of these diseases.
Thank you, Dr. Hirano. I also encourage anyone that has questions about clinical trials or needs help learning about them to please reach out to us. We're able to help. We can get information to you, and it's an easy way for you to learn more about the variety of clinical trials that are out there. Another topic related to treatment has come up a few times in the Q&A surrounding supplements.
Yes.
What do you think is the best approach for a family that's about to embark, or an individual about to embark on adding supplements to their care?
Okay, well, I'll give you a brief answer and then a more detailed answer. So the first answer is, if you ask 10 different mitochondrial disease experts about supplement cocktails that they use, you'll probably get 10 different answers. So there is no clear single consensus about the cocktail and what should be in that cocktail. Nevertheless, surveys of patients indicate that they feel that the cocktails are beneficial. So there is some benefit to taking cocktails. It's very hard to know how much of it is due to a particular supplement or combination of supplements, because we haven't done clinical trials. And there's also the possibility that there's a placebo effect as well. So this is an area where we would love to have clinical trials and data, so we can give you more scientific answers. But for now, we can say that supplements do seem to help people in some way. And I think you'll have to work with your mitochondrial disease expert and try to find a combination that may work for you.
Thank you. Couple other questions that we had, a few related to TK2D and the GI issues within that that specific disease. Is that something that is typically seen?
It's not typically seen. TK2 deficiency is a rare mitochondrial myopathy predominantly, so it affects limb muscles and respiratory muscles early. So often patients have respiratory issues, which has also come up in the chat a few times. So, but the GI system can be affected as well, and so patients sometimes have nausea, vomiting, diarrhea, constipation, and GI dysmotility issues that we covered in the presentation. So it's not very common, and it's complicated by one of the medications we're trying now, this deoxythymidine, deoxycytidine nucleoside therapy, which can in high doses cause diarrhea. So it's both a problem of the disease sometimes and frequently a problem of a experimental therapy that's in clinical trial.
Thank you, Dr. Hirano. That's very helpful. I have a question, two specific questions that are related to some of the medicines to avoid. One was about valproic acid. Can you talk a little bit about why that's avoided and the alternatives, I guess, that people might ask their doctors about? Yeah,
so valproic acid is often used as an anti-epileptic drug. It certainly can reduce seizure frequencies. However, in one particular mitochondrial disease, Alpers disease, which is caused by Pol gamma mutations, giving valproic acid can cause a severe liver disease, hepatopathy, which can be fatal. So in that situation, it's an absolute no-no to take valproic acid. And we know that sometimes valproic acid can be toxic to liver in general, and perhaps in mitochondrial disease patients more so, but particularly with the Alpers patients. So we generally try to avoid valproic acid in patients with mitochondrial disease, but occasionally when we're faced with patients with seizures that are very difficult to control, we sometimes have to use valproic acid, but it's done with great caution and monitoring liver enzymes carefully, and often giving supplemental carnitine when giving valproic acid.
Thank you. There's one more, I think we have time for one more question, and it's related to a more in-depth description about why, well, let me, before I preface that, I want to say, for those of you that have placed questions in the chat that we are unable to get to, we will do our best to try to get those answered post-event. But this question I thought was interesting because we were talking about it before this webinar began today. Metformin.
Yes, metformin. It's probably the most prescribed medication for diabetes after insulin, and it's a very effective drug. Unfortunately, metformin can be toxic to mitochondria by blocking complex 1. So we generally try to avoid using metformin in patients with mitochondrial disease, and particularly those with kidney dysfunction or kidney disease, because metformin is maybe more toxic in that setting. So, occasionally we use it, but there are many new diabetes drugs that can be used as alternatives. So, I would, if you need to use metformin, do so with caution, but please consider alternatives. And I think there'll be a future session on diabetes. Is that right?
Well, yes, we hope so. There's going to be one for the clinical community soon, and think it would be a really important topic to bring to our patient community as well. And in wrapping up, Dr. Hirano, I kind of like your take on adult care as we move forward. I mean, I think you did a good job of explaining that we have clinical trials and how important that is. But what other advancements do you see for the adult population that we might be looking for?
Well, I think that first I just want to say that we have absolutely zero FDA drugs, FDA approved drugs for mitochondrial disease. So we don't have any really proven treatments for mitochondrial disease, and from the pharmaceutical point of view. However, there is a lot we can do for mitochondrial disease patients in treating symptoms like diabetes or epilepsy or gastrointestinal problems. So there is a lot we can do to help improve the quality of lives of people with mitochondrial disease, both in adults and children. But I think it's probably overlooked in adults in many ways. So I think we can do a better job of caring for our patients and making their lives a little bit better, and sometimes significantly better with just supportive medical care, which is really important. I think you're muted. Oh.
I am. There was a little dog situation.
Okay.
Thank you so much, Dr. Hirano, for joining us this evening. We really appreciate your expertise, and thank you for addressing this really important group in our community. Our adults are, obviously we have 75 people on here today, which is a very large number, and I think they're always looking for information. So thank you for being here. Thank you for joining us, and we will see everyone next month on January 11th.
Okay. Thank you. Happy holidays.
Happy holidays.